Hello and welcome everyone to episode number 14 of our podcast. This podcast is somewhat unusual in that it is really a talk that we gave yesterday to our GBTQ plus community that we absolutely thought to make it into a podcast because there's so much information here, good information that every gay and bisexual man needs to know before and after prostate cancer treatment. Prostate cancer treatment discussions are often based on heterosexual data and erection-focused outcomes. But for many gay and bisexual men, sexuality, intimacy, identity, and role, top, bottom, versatile, matter in ways that are rarely addressed in clinic. In this powerful and candid session, we discuss erectile dysfunction beyond can you get an erection? Loss of ejaculation and what that means in the community, receptive anal sex after surgery versus radiation, penile shortening, climacturia, and real functional outcomes, hormone therapy and libido, sexuality, identity disruption, dating, disclosure, and relationship changes, treatment regress, and mismatch expectations. We also examine the limitations of common tools like the EPIC, which focus primarily on erectile firmness and frequency while often missing libido, desire, sexual role identity, and psychological impact. This session includes Dr. Christopher Wallace, a urologist from University of Toronto, Dr. Rob Rutledge, radiation oncologist from Halifax, Nova Scotia, and myself. I'm a psychology and digital health researcher here at Dalhousie University in urology, radiation oncology, and community health, and epidemiology. One of the most important messages from this talk, I think, is that treatment decisions must align with your priorities, not just cancer control statistics. The fact that survivorship is not just PSA numbers, it's quality of life, it's identity, it's intimacy. If your physician is not asking the right questions, bring them to them yourself. We are also actively studying and adapting survivorship care for LGBTQ plus men through the PC-PEP program supported by Movember, with early data showing meaningful mental health improvements when care is holistic and patient-centered. Visit us at pcpep.org for more information or to enroll in our program for free. It's a 6-month daily holistic program that has everything. It's taken issues related to intimacy, sexuality, but also nutrition, strength, social support, dietary advice, relationship advice, being in touch, putting you in touch with the community, with men in the community, but also a much more broader community where you can get the support you need. This is not just a medical talk, it's an advocacy conversation. If you're newly diagnosed, watch this before making treatment decisions. If you are post-treatment, you are not alone. And if you're a clinician, listen. Please share with any GBTQ plus men facing prostate cancer. Thank you for listening.
Perspective and
so excited. Chris, thank you so much for saying yes.
Yeah.
Of course.
Yeah. So you've met us, and I want to kind of address in terms of Gabriella's ideas, like how can we offer this kind of perspective to this underserviced population so they can understand, share that perspective with the newly diagnosed, and so that the men in the GBTQ plus community can actually really make good decisions, get good care. And hopefully the medical system will also adapt to this as this information is being shared. So we're very excited. I've been doing some major reading recently. And this is what we're going to talk about: implications of erectile dysfunction, the psychological and mental health issues.
And just before we go forward, I just wanted to give a shout out to Movember for really supporting this work. We are incredibly grateful to them and the foundation for sponsoring a research trial for the next 3 years that allows us to actually dig a little deeper into those issues and shed some light into barriers to care and barriers to survivorship care in particular.
Yeah, and I apologize if I'm excluding some of the population people were born with prostates is what I could say, or I could say sexual minorities. I might say gay, bisexual at some point. MSM is men having sex with other men. So, anyways, I just apologize if I'm not being totally inclusive in all my language here. As Chris is presenting, as we're presenting, I want you to kind of think about some of the issues that are very important from the men in the GBTQ plus community. So, for instance, erectile dysfunction, right? Because sexuality is very, very important within the community on average. Thinking about urinary leakage, just generally speaking, or at time of erection or time of orgasm. Um, the fact that after an operation, if the prostate is removed and you're what you call a bottom, meaning you're kind of having receptive anal sex, that can actually change that experience as well. We'll talk about that surgery versus radiation. The issue that, again, the experts, which are you men, brought up, talking about this whole issue of lack of ejaculate and how that has particular meaning within the community itself. Sexual self-identity. Do you see yourself as a topper or bottom? How do you express your sexuality within the context of erectile dysfunction? So there's some major issues that are specific to this population. And then, the big one is around disclosure and dating and relationships. And how do you navigate that? How do you navigate the medical system? How do you advocate for yourself? How do you make sure you're making good decisions, getting the best care possible? And so I'm trying to put all those kind of ideas up front. So as we're presenting, we're thinking about the consequences of treatments and how we can negotiate our relationships in the medical system. So, and I just want to say, I see Chris is really the expert from a urological perspective. I've been treating prostate cancer with radiation for almost 30 years, and Gabriela is an amazing psychology professor, scientist. But we also went to the literature. And so I've been reading from the scientists and urologists. And I want to special hats off to Dr. Thomas Gaither, who I really think is a world expert. He's been studying the effect of prostate cancer within the gay bisexual population for a few years. And I kind of scooped some of his slides from a YouTube talk recently. So excellent, excellent doctor. We reached out to Simon Rosser, University of Minnesota. He was part of the two major trials, Restore 1 and Restore 2, we'll be talking about. And then Daryl Middledorf is this amazing social worker who's been running this support group since the late 90s, malecare.org, for men with prostate cancer within the community. And then Gabriela will share her data, and we also have the conference results from the GBTQ plus participants. So I think of those as, actually it's you who are going to have this conversation afterwards as the experts. And so we'll share as best we can. I don't consider myself a real expert, but I'll share what I kind of understand. I'm going to stop share there and ask that Chris jump in and give us kind of overview, big picture, quality of life, surgery, radiation, etc.
Absolutely. It's a real honor to talk about it with the group. I think there's a couple of things to say. My slides are going to focus heavily on sexual function. I think from a surgery perspective and treatment decision-making perspective, I always start off with the premise that there's a base set of information that everybody needs to know, and then we potentially need to tailor additional information to meet individuals' examples. So a non-prostate cancer example, maybe, if you're going to go have thyroid surgery, there's a certain series of risks and benefits you need to consider. But if your job happens to be an opera singer, the risks and benefits are different, and you need to tailor that discussion a little bit. And so my takeaway would be that in any specific subset population, there needs to be the general information given that goes to everybody, and then a bit of tailoring that's specific to an individual's nuance or the group that they're part of. And I think it's important as we do that not to let group identity trump individual identity. So while we're going to make some statements about groups of people, there's a lot of variation within groups. Potentially as much within groups as there is between groups. And so I think it's key that as you interact with your own physicians, you make sure that they understand your priorities and your concerns, And you don't just get generic information that relates to the average patient, but you can get a tailoring of that to you. So this is sort of the context we'll go through. I have a bunch of slides. Many of them will go through relatively quickly, but I want to start this whole discussion. People see the word prostate cancer or hear the word prostate cancer, and cancer carries a lot of weight. But as most of you will already know, there's so much variation within prostate cancer in terms of what this means as a cancer risk, and conversely, the kind of trade-offs we're willing to take to treat it. So, more aggressive cancers, maybe we're more accepting of a little bit more side effect. Less aggressive, we maybe should have a higher bar where we demand that we really minimize our treatments because the cancer risk is lower. So it's important as you approach all these decisions to think about what's the cancer risk and what is your goal in treating it. What are you trying to achieve? And so there's some great studies done, and I'm just going to throw this one out, which is to say that many men report that they're willing to give up a little bit of the effectiveness, the cancer control of their treatment in order to protect their quality of life. And if that is you, it's important that your physicians understand that. Some men will tell me, sexual function is my be all and end all. Without it, my quality of life goes to almost nothing. And I tell them that if that is true, surgery puts that at risk, and maybe you want to consider alternative approaches. So for example, Gleason 7, intermediate risk prostate cancer, but if it's on the less aggressive end, we may tolerate a bit of a period of observation in order to preserve quality of life. Whereas for other men who have a cancer-specific priority, we may be a bit more aggressive with the cancer therapies. So I highlight this to say that if you ask men, the same things align. While curing cancer is a priority, preserving quality of life is nearly as high a priority. And so we really need to align these two. And when we think about prostate cancer treatments, a lot of focus is on urinary and sexual function. That's the nerves and the anatomy that are intimate with the prostate can affect urinary and sexual function. And so we need to distinguish here between symptoms, which are the things you can describe, and bother, which is the impact on your life. And what we ideally want to do is get good outcomes in both domains, but most importantly, we want to minimize bother. We want to minimize the negative impact on quality of life. And so there's a variety of studies. I'm going to show you a couple just to highlight initially why the real importance of the patient voice. So this is a study, comes out of Italy. It's a randomized trial, but it shows different outcomes for patients treated with surgery and brachytherapy, one form of radiation. What the results aren't really that important, but what I want to highlight is that this is what physicians think is going on. And essentially, physicians think, at least in this study, that everybody does pretty great. The proportion of potent patients that you'll look at 6 months is 75% or higher in the surgery arm, and 65 or 55% or so or higher in the brachytherapy arm at 6 months. Like, I'll be honest with you, as a practicing clinician who operates a lot, that's a bit crazy. And that's a bit crazy because physicians at the end of the day do not really understand what patients experience. You don't need to understand this curve except to hear that the agreement between what a physician reports as outcome and what a patient reports as outcome is quite poor. We underestimate the burden of treatment. And there's other data, and we're not going to present it here, but roughly it's a 10-fold difference. Patients will report 10 times more symptoms than the clinician will gather. And so one of the ways we've tried to address this is to bring specific surveys and really well-validated tools to capture the patient experience. And so I want to highlight, this is probably the most commonly used one looking at sexual function in prostate cancer, called the EPIC, Expanded Prostate Cancer Index Composite. And these are the questions that are asked about sexual function. And you don't have to go through all of them, but what I want to highlight here is that it is a very erectile-centric measure of sexual function. It very much focuses on how reliable, frequent, and hard an erection is, predominantly to the exclusion of other aspects of sexuality. So this doesn't really ask about the relationship components. If, within the community we're talking about today, if you are on the receptive end of penetrative intercourse, that whole experience is not reflected here in any way. Things related to oral sex are not reflected really in any way. It's about the ability to get and maintain erections that drives almost all of the questions here. So I think it's important to understand the limitations about what prostate cancer scientists have studied historically, in part because these are the tools that we've used to study it. So that said, this is the historic data comparing patient-reported outcomes. What you'll see in terms of erectile dysfunction, so here greater is a bad thing, there's more dysfunction. Depending on the study, it's either equivalent or somewhat worse in surgery-treated patients than radiation-treated patients. And building on that, we have newer studies, and one of the ones I want to talk to you a little bit about is a study I've worked a lot on called CSER, which is an acronym for the comparative effectiveness of surgery and radiation. And so this is some of the first data, and what it shows you is higher numbers here are better function. So you want to be towards the top of the curve. So surveillance in green is observation strategy where you're not getting treatment, and that gives you better sexual function than either form of treatment. Now, the keen-eyed among you will notice that on the left side, the blue line starts a lot higher than the purple line. So patients who go for surgery tend to start with better erections than those who go for radiation, in part reflecting the fact that surgery-treated patients tend to be a bit younger. And we'll come back to the impact of age as we move forward. But you'll see that there's a drop-off for both groups, and then it relatively plateaus somewhere between 6 and 12 months and goes on thereafter. These are data from the randomized PROTECT trial, again, showing a big drop-off up front and then relative stability thereafter. When I put those studies in aggregate, what I would say is up until about 2 years ago, we either had treatments that were outdated, but we had good long-term follow-up, or we had treatments of modern approaches, but relatively limited follow-up. So we couldn't tell you, long-term trajectories. We could say 1, 2, maybe 3 years. And so we've tried to address the intersection of those two to get you modern treatments, but long follow-up. And this is particularly important because things change over time. So this is an outdated treatment study, to put it into a box, but follow-up out to 15 years. And what you'll see is that differences that seem really big at like 6 months, where these blue and red lines are not even close to each other, become quite small, and the lines almost touch each other at 5, 10, 15 years. And so things change over time, and the differences between treatment approaches change over time. And understanding that nuance is, I think, important to giving people realistic expectations about what to expect. So this is our most recent study. It's done in a variety of sites across the US. I'm not going to belabor the point, except to say that one of the key takeaways here is that we can't think about all prostate cancer patients the same. And in particular, we need to think about differences between where you start. So in this case, what is your erectile function before you go for treatment? I say to my patients, it's never going to be better than it is today. And whether that's because we don't touch you at all, but you just get older and age is going to take away sexual function, or whether it's because we offer you treatment, surgery, or radiation that's going to make it worse, there's nowhere to go but down, unfortunately. So this interplays with the aggressiveness of the cancer and correspondingly how aggressive we need to be in our treatments. So in this favorable risk subset, and by that I mean a low or favorable intermediate risk prostate cancer, and the key here is really that if you get radiation in this setting, you don't need hormone treatments. And that's the big distinguishing characteristic of this group of patients. And so what you'll see is that the patients who get radiation in this group have a fair bit better sexual function than the surgery patients. The surgery patients are the red ones, and they all start off about the same here, but there's a big drop under surgery. It comes back up. By about 5 years, it's not statistically significant, and by 10 years, it's nearly overlapping. But there's a period of time, certainly 3 to 5 years, where the surgery patients up front have much worse function. Now, interestingly, if you go to the unfavorable risk, so that's unfavorable intermediate risk or high-risk prostate cancer, that's a patient population where if you're getting radiation, you need to have hormone therapy that takes away your testosterone. You'll see that the sexual function is interchangeable between surgery and radiation treatments. And so a really key is in this group, erections are likely to be really bad no matter what we do. And I think that's a very important level setting for all patients. So in our group, about 50% of men had erections that are good enough for intercourse or for penetration when they started the study, before they had any treatment. And of those, only 13% getting surgery, that's about 1 in 7, and 11% getting radiation, so that's 1 in 9, got back or kept their erections good enough for intercourse, which is to say that if you have aggressive disease and we need to offer you aggressive treatments, regardless of what treatment we choose, your erectile function is going to be quite poor. And so, reconciling those two data points, we start off with the patient factor, we think about the disease factor, and then we try and give you some realistic goal of where to move forward. So this looks at hormone function. Not surprisingly, if we give people androgen deprivation, it affects their hormones. And that's key because, stepping back to that more holistic picture of sexuality, a lot of our tests focus on the ability to get and maintain an erection. But interestingly, like on the surgery end, we'll get to the question about ADT and we can go over that detail. But on the surgery end, the testosterone tends to stay relatively preserved. And as a result, libido or sexual interest remains preserved. But when you give hormone therapy and ADT, a lot of times sexual interest goes down. And that may be frankly beneficial if your erections are not there anyway. You can't have sexual intercourse. Some people see the loss of interest as, maybe it takes away that bother because you can't get an erection, but now you're less interested in it. Whereas other men find that it interferes with the non-erection part of intimacy. And so, that change in libido has varying impacts for different men in different situations and maybe on relationship status and things like that. So that's, the erection data there. And I think it's important. This is one of my favorite slides. Alicia Morgans is a medical oncologist who's a really good friend of mine, now working in Boston. So she puts it this way, and I think it's important to think about. We have talked a lot about what we call everything I presented to you so far is PROMs here, patient-reported outcome measures. And those are really great tools to get the patient voice, but they don't capture everything. So there's PROMs, then AEs is what the doctor would see as a side effect or a toxicity or a complication. But then there's all this other X factor, and this is things related to the burden on relationships and families, inconveniences, anxiety, that may contribute to the broader picture of being a patient with cancer and needing treatment beyond the things that a simple survey can capture. And so as you think about treatments, we can capture the adverse events, the AEs, really well. We can capture the PROMs reasonably well, and we capture this S factor very poorly. And there's also a lot of variation between patients on the X factor. So anxiety has a variety of different manifestations. Some patients may get anxiety from watching their cancer, knowing it's not treated, even though it's low risk. Other patients may have, a huge burden related to needing to come to the clinic for multiple radiation visits because they're going to get many treatments. Some patients may have real impediment in quality of life because they need to take some time off work for surgery. And so the nuances of these features need to align with your specific life and your lived experiences. And so as we try and put that all together, what we're trying to do is avoid regret. We want to help you get the information you need to make a treatment choice that feels good and aligns with your values. And the way we know retrospectively that we've done that is a few years down the line, you think back and you feel okay about your choice. You don't regret it. And so that's not going to be perfect every time. And so this is, again, one of our studies we did. 1 in 6 men has some degree of regret, and in a systematic review, it kind of comes out similarly. But I think the biggest driver for regret, and I want to highlight here, is not really the treatment you chose or even what your functional outcome is. It's about this idea of what's the difference between what you thought was going to happen and what actually happened. So at the end here, you see this perception of effectiveness compared to reality or received outcome. And so put a different way, if the rate of regret is 13% in the old group, if you thought the treatment worked less well than you thought it was going to, 70% of men have regret. And if your side effects are going to be much worse than you expected, about 50% of men have regret. So really this comes back to me, the key is to align and give appropriate and realistic expectations before we embark on treatment. And that can help people sort of fit the treatment and the treatment effects into their lifestyle in a way that is compatible with their living. And so that's really the key of making sure that, as physicians, we understand what life looks like and what matters to you. And as patients, making sure that you gather the information you need to understand how the complications or side effects of therapy are going to affect the things that matter most to you. I wish there was an easy way to do this. Things like decision aids have been tested. The reality is they don't work as well as we think they do because they're kind of generic. And what we're highlighting is that the nuances of individual patient choice can't be captured by some generic tool. And so this is about the conversations you have with your physicians, but also after with your physicians, with your friends, family members, spouses, partners, to really make sure you come to a treatment choice that aligns with your priorities and your values. And I've given this in a very sort of across the board way, but I think Rob's going to help dig into the nuances as it fits into this population. I want to just highlight that if we do patient-centered care, it feels good, it seems like the right thing, patient satisfaction goes up, but even more than that, we get better clinical outcomes. Pain scores are lower, psychological distress is lower, quality of life is better, and even disease-specific outcomes. In some other cancers, it's been shown that survival outcomes are better when we give patient-centered care. And so I think as clinicians, this is our obligation to you. And if you feel like you are not getting it, either talk to your physician about it or look at second opinions. So my sort of brief takeaways here that what we know and understand about sexual function in the context of prostate cancer treatment is very centered on erections. And it's very much about how often, how frequent, how reliable, how hard. And while that's an important part of sexuality, it may not be all, and it may not be the most important part for you. And so making sure that you understand the limits of what we know and that your physician understands what is important to you is really, really key. The risks of erectile dysfunction really start with baseline function, where you're at before you go on to treatment, and then are heavily dependent on the disease, what we know about your prostate cancer and its aggressiveness, and the treatments you get. And when we're trying to do the best for patients, we want to avoid regret and make sure people come to choices that they feel good about. And we were talking about before this meeting started, in Canada, we're maybe a little bit lucky. We don't compete or fight for patients. If anything, we have more patients to treat than time to get people in for surgery or radiation. And so I think we really want to be reasonable. We don't want to oversell. We don't want to overpromise outcomes, and giving people realistic expectations, even though it may not feel good to say or good to hear before treatment, is really important in setting people up for success in their survivorship journey. So I'm going to leave the slide portion here, and I'll let Rob walk us through the next part of it.
That is a perfect segue to talking about all the issues that gay and bisexual men face. Because really, I think if the men understood the full extent of both the possible side effects and have that really good conversation with the urologist, radiation oncologist, I think they would make better decisions. And I also think there's a place for mentorship where men can talk to other men who've had a prostate cancer diagnosis who are part of the community to kind of share their experiences. And so men going into that decision-making process make a better decision.
Yes, and I think one of the reasons we're so excited with the way the PC-PEP program is organized is that it allows men to go through a program that is extensive in terms of health promotion, healthy eating habits,
sexual health promotion,
sexual habits that they can adopt during the program, put in practice after the program, become mentors for other men in the program, but also start getting educated on a lot of those issues, because it does take time to assimilate information, to put it in perspective, to see how it lands with you and your life experiences before you can start creating a smaller community within a large program that is now global, where you can actually really start giving back and starting a dialogue that is much more easier received. Because men can talk to one another in ways they can accept and understand, using language and experiences that they can relate to one another, rather than the top-down approach, which, like Chris says, uses physical models that oftentimes patients just don't have. They can't relate. And so then they try to make sense of that information. It's more like taking whatever information they receive and trying to fit a picture that they have already in their head, but the two may not match. And so then expectations,
it's around expectations.
It can lead to regret.
Agreed.
Yeah.
Well said. So the first study I'm going to talk about, published in 2016, and I'm just going to touch on these very briefly, but essentially it's a large survey using what they call patient-reported outcomes. So the problems that Chris was talking about, using validated questionnaires. Again, they sometimes have their issues as well. But essentially, if you compare what are the demographics of the gay bisexual men, 50% of them were single, right? Whereas only 14% of the heterosexual men. So you're already having a kind of a different population, different issues within the GBTM plus community. So if they were in relationships, 19% of the gay bisexual men were in relationships less than 2 years versus only 7% in the heterosexual group. And then they were having, the men in the GBM group, 40% were having casual sexual partners, whereas only 4% within heterosexual men. So there's different relationships, different expectations within that community, right?
And different needs, psychological needs.
Yeah. And interestingly, in this study, the men in the GBM group actually had a better sex life, generally speaking, than the heterosexual men. So they are probably more sexually active on average. However, they also reported greater psychological distress, which we've seen as well, right?
Yeah, data.
Cancer-related distress and anxiety. So they're worried about, whether the cancer can come back or not. Erectile concern, so ejaculatory concern. So this issue of not having ejaculate has a whole extra meaning within the gay and bisexual community. And overall, Chris was also talking about this kind of treatment regret, because they're running into all these issues that they didn't necessarily know about. So that's the first study that says, there's a real difference on this side. And then Thomas Gaither, he's on the cutting edge talking about receptive anal sex and trying to match what the sensations were with the kind of neuroanatomy or the nerves anatomy within the pelvis itself. So qualitative study of 30 individuals born with a prostate, essentially. He participated in bottoming, so essentially anal receptive sex. And he mapped out these different kind of sensations, and it maps out to the kind of nerves. So for instance, the front of the rectum, which is where the prostate is, the men would describe feelings of tingling, massage, electric, pressure feeling, et cetera, et cetera. The anus and the kind of pelvic muscles could also give different sensations, tickle, tingle, warmth, et cetera. And so there are different ways that these nerves produce these sensations, and a change in prostatectomy can potentially, not for all men, change the sensations and so on. And we're going to talk about how radiation may influence this as well. So again, this is like cutting edge science to try to figure out what is the actual experience of a man having anal receptive sex. This is the Restore 2 study, and essentially it was 400 men that were randomized. They're all part of the GBM community. And essentially half of them got some pretty good resources, pamphlets, support groups, et cetera, et cetera. Half of them were like, you go home and you figure this out yourself. So the usual type of stuff. And then they compared their experience with all the men, comparing surgery versus radiotherapy. And so kind of like Chris was talking about as well. So RP is the radical prostatectomy surgery. EBRT is external radiation. And so radiation had less climacturia, which is essentially dribbling or leakage of urine at time of climax. So 11% in the radiation group versus 59% in the surgery group. So worse for the surgery guys. condom-related erectile dysfunction is kind of a weird one. It's like if you put on a condom and then you lose your erection, that was also seen more in the surgery group versus the radiation group. And these guys were at various times of follow-up. Decreased penile girth and length. I'm going to ask Chris later if, post prostatectomy, it seems that there can be a little bit of shortening of the penis as the kind of surgery retracts in the tissue. So less length and girth issues in the radiation group, more in the surgery group. But there are higher rates of anodyspareunia, is essentially pain in the anus on having sex. So it's the bottom guys. It will be higher rates in the radiation side and lower rates in the surgery guys, which makes sense. The radiation is causing that irritation. And so they said just generally one of the principles may be if you are a bottom, typically you might choose surgery. If you're a kind of on a top, you might choose external beam radiation because you might be able to maintain your erections for at least a little bit longer on that side. Granting that things.
Excellent science here. Yeah, mapping onto what men appreciate.
Yeah.
And value during sexual intercourse.
And Chris, and this is we're gonna kind of go back to this. So you talked about this. Should every man expect that the erections be at least a little bit worse after a prostatectomy? I guess that's the first big question for you. Oh, and just unmute, yeah.
Sorry. So, I mean, I think the first thing to start off is just to say, a good understanding of where you begin is key. As I sort of alluded to, it's never going to be better than the day it was when you're diagnosed or than yesterday, right? Erections in general aren't going to get better. Now, there are both transient and long-term effects. So I would say immediately around the time of surgery, everyone should expect that their erections will get worse, at least transiently. And then the answer beyond that really depends on the cancer and what kind of operation is able to be performed. So if you have a less aggressive tumor, or you get, say, maybe a tumor on the top of the prostate anteriorly, we can be pretty aggressive with sparing and protecting nerves that run behind the prostate. And if you get a good bilateral nerve spare, I quote people about a 50% chance of getting back to where they started and a 50% chance that it'll be somewhat worse than they started and may need, medications or something to top up. Now, if you have a lot of disease in like the base of the prostate, and we need to go wide on both sides, and we get essentially no nerve spare, you have probably a less than 1 in 5 chance of having good spontaneous sexual function. And so the key always is to understand that there's the natural level of function and then what we can do to improve upon that. So you can do things like, you can consider oral medications, you can consider things like vacuum pumps and cock rings, and in addition you can think about injectable therapy. So something called intracavernosal injection can give most men an erection if they're willing to go as far as injecting into the penis. So it's like a needle about the size of an insulin needle directly injected into the penis. The vast, vast, vast majority of men are going to be able to get a decent erection with that. But the question is, are you willing to do erections into your penis to get it? And so, the honest answer is that temporarily, almost everyone's going to lose it, at least transiently. And most people should expect it to be somewhat worse than it was before, with varying degrees, anywhere from 90% of where they started down to like next to nothing. And I think that's the honest variation. And a little bit of it's unpredictable. To actually be able to give you a perfect answer what to expect is a bit of a fool's game, but we can certainly bring factors in that help guide us in terms of understanding where you start, understanding the disease. To some degree, it's about understanding your priorities. So I'll tell people, we have to think about nerve sparing like peeling wet paper mache off a balloon, and we want to neither pop the balloon nor tear the paper mache. And it's not a super easy task, to be totally honest with you. And so some of it's not even known until we're in the surgery, and how the tissue planes react and how successful we are with our nerve spare. So we can have a plan going into the operation, and we try to execute it. And sometimes we're more successful than other times. But I'll let the patient sometimes dictate to me. I'll say, if it's a little bit uncertain, do you want me to err on the side of leaving more nerves and protecting your function at the risk of leaving a bit of cancer, positive margin, or do you want me to be more certain that we get a good cancer treatment at the risk of worsening your function? And different people approach that trade-off differently. And so I'll specifically say, like, in the case of uncertainty in this operation, how do you want me to lean? And different people will answer differently. And I use that to guide how I make those qualitative judgments during surgery about how much risk to take.
Wow, it's so good to hear the world-class surgeon talk about this stuff. Okay, so dry orgasms, it's going to happen. There's going to be no ejaculate post-operation. And just to suggest that what we heard from our community, our peppers at our conference, was that can be a big deal, right? There's a meaning to actually have an ejaculation, to have that experience with your partner or even with yourself. So, yeah, yeah. So, anyways, yeah. So, and we talked about this idea that you could be leaking some urine at time of climax, and even if you have an erection. And so it's estimated maybe 30% would have urinary leakage during orgasm. I guess the other slide had 49%, but anyways, it's there. Chris, you can jump in at any point. Should I come in?
Some of those things you can adapt to. I mean, like climacturia, you could talk to your partner and say, look, there's going to be some leakage during, can we adapt to this? Can we pivot? It's not going to be the end of the world. Can we?
Yeah. The best trick there is to do the best trick for climacturia is to do the opposite of what we tell women to do. Women around the time of intercourse, if you want to avoid UTIs, we tell them to pee right after sex. The answer for climacturia is pee right before sex, and then your bladder is empty. So this all comes down to spasm in the pelvic floor, and it's a good thing. It's part of the orgasm experience, is that the pelvic floor contracts in these waves that are a bit uncontrolled. But in doing that, you kind of lose control of your bladder a little bit. And so if you lose control of your bladder, but the bladder is fundamentally empty, very little is going to come out. Whereas if your bladder is full at that time, you may have significant leakage. So the single best trick to manage climacturia is just start to have intercourse on an empty bladder. And
excellent.
Everything else we do medically falls secondary. There's, in terms of pills or other things to do, nothing works as well as just having sex with an empty bladder.
Excellent. I love the practical advice. What do you tell your patients, or what's your expectation thinking about surgeons across the country or worldwide? How much shortening does it kind of stretch out over time? How much is this an issue?
Yeah. So it's a real thing. Penile shortening for sure happens. Probably on average, most people lose 1 centimeter to 2 centimeters. So that's like half an inch to an inch is pretty typical. Often there's more, in my practice, I would say the difference is sometimes more visible when the penis is not erect than when it is erect. So the flaccid length actually decreases more than the erect length. And the studies that have all been done in a very weird way. They measure penile shortening, what they call flaccid stretched length. So it's not with an erection. It's like in a doctor's office, someone grabs the penis and stretches it as far as it can go while it is flaccid and then measures it. So it's a really weird and unnatural way to think about what the length of the penis is. But there's variation again between men. And the two big factors to think about, number one, is body habitus and how much people weigh. And that's part because the suprapubic fat pad, or the pad that sits, the fatty tissue that sits in front of the pubic bone, buries the bottom of the penis. And so the more suprapubic fat you have, the more penis is actually hidden. So that's part one. Part two is the size of the prostate. In general, I don't have great data to quote for you here, but my experience is that the bigger prostate, the more shrinkage you experience. In general, when you think of the operation we actually perform, for the most part, we pull the bladder down to the pelvic floor to get the actual operation performed. But for whatever reason, some portion of the urethra gets pulled up, even though I feel like I'm pulling bladder down more than I'm pulling urethra up. So for whatever reason, when there's a bigger gap there, it tends to be
more
that there's
tension,
a bit more shortening.
Yeah, excellent. So then we are also talking about this question of, if there's no prostate there and you're a bottom, that you're going to have different sensations. Now, it seems kind of my read of the literature is it doesn't happen for everybody. And I'm not sure that the top, the guy who's having having his penis in there, it actually has a change in the sensation, but I don't know the answer to that one. So anyways, there could be some change in sexual satisfaction for the bottom, and not every man. I just wanted to again show this picture of radiation. So the left-hand side is kind of cutting through your body, through your hip area, and what I'm trying to show is that the back part of the rectum is just behind the prostate gland. The coloring is the distribution of radiation. And because the radiation oncologists always have to capture extra normal tissue, you're always going to have full dose of radiation to the front part of the rectum. So that's the truth. You're going to get that kind of radiation burn in the short term, and it's why you would not want to have receptive anal sex for this first probably 2-3 months after radiotherapy. And it's possible that that kind of irritation or that sunburn can continue and cause a discomfort in the longer term. So it's the reason why receptive anal sex may be more problemsome in the troublesome in the men who have a radiation treatment. And that's just the side view. Seeing the bladder up top, the bottom of the bladder is always going to get irritated. High dose radiation is going to hit the front of the rectum, and that's the penis would get to that area on anal sex. Okay, so then the takeaway from my side is, and we saw it on those graphs, is that we expect the radiation side effects to worsen over time. You kind of get more scarring, the blood vessels get a little bit more narrow, and the men are getting older at the same time. So the takeaway is you might have a little bit of a honeymoon period for, who knows, 6 months, a year, maybe even 2 years before then those curves start to come together. And I say overall the chance of having erection problems after surgery is very similar to having erection problems after radiation treatment if you wait long enough. And again, all those other factors around how good are your erections before your operation or your radiation, whether you're using hormone therapy, et cetera, et cetera. So there was a question in the chat, like, why would you be adding hormone therapy to radiation? And it's for two reasons. One is the hormone therapy can have its influence everywhere in the body. So the hormone therapy may be able to sterilize that one cell that's floating around. And so that can actually improve the chance of cure. The other one is the hormone therapy probably kills off about 99% of the cancer cells, making it easier for the radiation to sterilize the last of the cancer cells. So that combination of hormone therapy plus radiation is better, especially for the bigger and more aggressive cancers. So we have to compare apples and oranges, right? So if you're talking about, deciding what you want to do, you have to really understand if you're having hormone therapy, that's a whole other set of side effects that, as Chris outlined, affects erectile function, affects libido, affects lots of other things.
Yes, and I'm just thinking in terms of ADT, one of the side effects is decreased mood, symptoms of depression, anxiety. And what we noticed, Hugh et al. In the States did a major study of over 8,000 patients, and they found out that patients go through the back door, see their general practitioner to get prescription for their depressive symptoms, things like benzodiazepines, which negatively interact with ADT therapy. So it shouldn't be done. So the prescription doesn't happen by the oncologist. In fact, the oncologist doesn't even know.
Right, yeah.
And although the first course of therapy in issues related to depression and anxiety should be therapy, only 1% of the men decided to go for actual therapy,
taking care of
and
themselves.
The majority went after benzodiazepines, which of course interact with ADT. So keep that in mind. There's also that whole issue around side effects and how do you deal with them,
right?
And the effect they have on your sexual experience, short and long term as well.
Yeah, and why we have to take care of the whole person and not just one issue. So ejaculate is definitely decreased after radiation treatment. So 18% of the men had no ejaculate. Probably 85% of men had reduced ejaculate. So again, maybe not as big an issue, but definitely less ejaculation. And I talked about this already. At least 10% will have ongoing issues of anal receptive sex there. Now we're getting into the psychological issues there. So I'm thinking about men from the community more likely to be single, right? More likely not to have that kind of intimate partner support. And really, there's this huge issue around isolation, right?
Huge, yeah.
So that's that's a huge risk factor just by itself.
And you'll see in a second the results that we obtained in our own Pan-Canadian international trial when we looked at GBTQ men compared to heterosexual men, and how they come in the trial, they come to start the program with much higher rates of depression, anxiety, or both, psychological distress. And the program really helps them, in fact, even much better than the heterosexual men, to eliminate those issues.
Right, exactly. They're a need, and
but it is a need, and I think we need to really stress that there are so many complexities around relationships, especially when you're single. Yeah, you can have multiple partners, but with that comes also anxiety. So there are some very complex issues around GBTQ plus community. Context that I think it's worth looking at,
and including this is the issue really big time, is if your sexuality is really important within your relationships, or that's expectations within the community, then how do you disclose that to potential partners, or how do you tell your own partner? Absolutely. And, how do you look at yourself? Am I like a damaged good now that I can't have an erection as good as I used to, for instance, right? So that's a whole stress by itself. And then, one of the studies was talking about if you're a top, you become a bottom. But a lot of guys who are top don't want to do that. They have this kind of self-identity as that's what I do, and therefore it's a loss. It's like a real grieving loss of sexual function. And like any grief, that takes time to work through.
Right? Yeah, and I think knowing about those issues, what gets damaged, what can I live with? What is it I can't live with?
Yeah.
It will also allow you to make decisions that are more in line with what you're prepared to let go of and what you're not prepared to let go. Because now with all the wonderful treatments that we have for prostate cancer, we're treating the disease, but are we adding just years to life, or life to years?
How can we support them? And then there's this whole issue of having discrimination against you in lots of different realms within your life, and then you walk into the medical system and you still feel that kind of sense of discrimination. There are examples of the receptionist, like, did you bring your wife along scenario, and so it's just not, it's not conducive to good psychological health overall. And so we do know there's increased mental distress compared with other communities. And that, basically nearly half the men reported experiencing discrimination. They felt it was related to their sexual orientation. And this is linked to lower health-related quality of life. That because you're not being taken care of and seen as, who you are, that's very stressful. I love this quote. Ultimately, you realize you're on your own, right? Ouch. Having to negotiate this yourself. And that's why I want the guys to reach out to the prostate cancer support group communities, and the PC-PEP that has this particular population, and so on. So there are significant issues around communications, challenges, disclosing your sexuality, and so therefore limited conversations. Chris is a fantastic urologist. It's obvious. How do you facilitate that type of conversation with your urologist, wherever that is? So, and then you've seen, a lot of these other points here as well. So this is where PC-PEP comes in, and I thought to give like a very super quick overview for those who know nothing about it. Yep. So we designed the program really at first to address the mental health issues, and the guys in the GBTQ plus community have the high issues there. We could mitigate against particular side effects, including urinary incontinence, but erectile dysfunction, doing Kegels helps on that side. Hormone therapy has its own set of side effects, and the guys are more likely to die of cardiovascular disease than of prostate cancer. So in the guys, there's like 98% chance of prostate-specific survival at 10 years. So we want them to be healthier overall there. And so people can go to pcpep.org. We have the various countries have their own sub-pages. There's a 10-minute video that explains the program. And then you can basically sign yourself up. And we are looking right now through the Movember grant for more men who have a prostate cancer from the community. So educational resources. I'm not going to take you through all of this, just to say we have an overview. But one,
And for gay men, we just, because of the work that we're doing right now with health equity, the help of the GBTQ plus community in the program, we designed an introductory video for
yes,
GBTQ plus men entering the program, just letting them know
yes,
some of
all
those
these
issues that we
issues.
talked in this presentation, for them to have the heads up, to hopefully help them in their treatment decisions.
Navigation
Yeah.
and so on. Yeah, opportunity to connect with mentors within the community itself. And also, I mean, part of that was what's the language you use to be able to, talk about those issues with your oncologist. And the big picture is you can't expect your urologist or radiation oncologist to bring up those topics that are important to you. So you have to kind of advocate for yourself and then ask those very specific questions. What's my chance of having erection problems in the long term? This is important to me. What's my chance of wearing a pad in the long term? Usually you go to about a year because your body continues to heal over that first year. How will hormone therapy affect my sex life? So really asking the very direct questions. And another thing I encourage people to do is, if your doctor is not clearly communicating with you, stop them and say, I'm not sure I understand. Can you re-explain in simpler language?
All right, or it's as simple as saying, okay, look, I'm not very familiar with the anatomy of all this. So do you have some physical model? Can we actually go through your explanation
Draw a
step by
picture.
step?
Yeah.
And I will also tell you that the things are important for me according to my perspective,
Yeah.
so that I have a better understanding of what my options are realistically, and perhaps what choices should I make that I can live with, that I can still be happy and have a good quality of life. So don't be shy to say, this is what I'm looking for.
Yeah.
I don't particularly understand your language.
Yeah.
You're using words that I'm not familiar with. You have physical models that you're explaining to me that I don't have an image in my head, and I don't have the building blocks to put them together because I've never been exposed to them prior to receiving this diagnosis. Can we sit down? Can you talk to me the way you would talk to your neighbor, to your grandfather, to your father, to your friend, to your sibling? Yeah.
So the guts of the program, 182 daily emails and these little PEP videos from Gabrielle and me in our kitchen. There's a whole curriculum on the daily emails that takes you through all aspects of the program. We're asking you to exercise every day almost, not to sit too much. There's strength training by video, 4 levels of difficulty. It's safe. Over 800 men have done this program. We give you the elastic bands and so on.
Yeah.
So there's dietary advice. You're seeing one of the 26 cooking videos. In the meantime, every day we're emailing you to kind of slowly change your diet to a healthier diet. Pelvic floor muscle training is good for not just the urinary leakage, but actually helps the sexuality side itself.
We showed that in our randomized clinical trials, especially men undergoing surgery had a little better remission on their sexual symptoms compared to men that were not in the program. This is an intensive, progressive Kegel's regimen, is based on a translation of the top-notch randomized clinical trials on pelvic floor muscle therapy. And we showed results at 6 months, 12 months. Now we have extended the program. As I said, we have a pan-Canadian international trial. We see that the results map exactly on the data that we had with a randomized clinical trial. So that's very encouraging. Though I need to tell you something, Jens, and I'm really happy, Chris, that you talked about that complexity around GBTQ plus community. You did that as well, Rob. We did some very interesting studies, and we're just publishing the results now. Actually, this particular paper that I'm talking about just has been accepted by the Canadian Urological Association journal. But basically what we did in this randomized clinical trial, we thought, what an interesting data. And we noticed a decrease in psychological distress among all men that were in the trial. We said, well, why don't we look at the possible mediators? What are the mechanisms? How come this program is helping men, have lower psychological distress, lower depression, lower anxiety, better urinary function, better, as I said, even sexual function, just for the surgery guys? Very well. We did a mediation analysis, and we looked at self-efficacy and the activation of the patient's own role in their care. And lo and behold, almost 50% of the improvements in psychological distress and other outcomes were due to the activation of the patient in their own care,
Yeah.
self-efficacy,
Taking active
perceived
role.
control over your life, over your destiny. Then we said, well, they also had better urinary function using the IPSS and the EPIC that Chris talked about, EPIC 26. So we said, let's look at it as a possible moderator. Why not? Mediator. Why not? After all, men had better urinary symptoms, better sexual symptoms. Do you think that urinary function and urinary symptoms mediated the effect between PC-PEP or standard of care and psychological distress? No, it didn't.
Interesting.
So this is very interesting. And I think the trial is going to receive a lot of citations because here you have it. There's so many complex issues. I have so many partners. I don't have partners at all. I'm isolated. I'm battling so many things. Those are complex issues, a lot of which don't necessarily have anything to do with erectile dysfunction or erectile function for that matter.
Or erectile urinary
just caution you against, bringing
in
this issue and making it the be all and end all, because it just may not be. We may just not have the science to support that.
Yeah. I'm just going to briefly say 10 minutes of meditation or relaxation daily with the biofeedback monitor. Prescribed intimacy and connection exercise. So this is where you start to learn about a healthy sex life, maybe outside of good erections. So,
yes.
Right. So love languages, emotional needs, etc.
Yes.
So that
penetration or non-penetration, you can still have a wonderful sex life.
And prescribed activities around that. We're still doing monthly video conferences. We're getting about 60 screens per month. And then this is the buddy system, right? So the men within the community can connect with other men part of the gay bisexual community as well, right? And so you get those mentors. We have the small group discussion for the GBTQ plus community. And that we modified the program, right, so that the men would be connected more easily. There's a specific web page for the community. You're starting to do podcasts with these gentlemen as well.
The gents in the group are absolutely phenomenal. Yes.
Right. And Chris is number one urologist being invited to come and talk to us. Small and large group discussion.
Yeah.
Yeah.
And just a scene of shot at the results that we obtained when we looked at the pan-Canadian international data. We have about 700 men in the trial, and we did a brief comparison. Those are evaluations that both GBTQ plus men and heterosexual men give at the end of the program for each component of the program. And so overall, GBTQ plus men rated the program much higher compared to the heterosexual men. But the interesting part is this, that GBTQ plus men came in the program with worse baseline mental health. They had greater improvements over time and about 10% higher retention at 6 and 12 months. So it's wonderful, very encouraging to see that this is a program that actually is supportive of this community. And
just to say that we're still accruing men from the community, because we've done the first cohort of the first 25 guys to get this feedback to make the changes. Now we're going to do the second cohort of a new group of men to see if they actually like the program more than the previous program.
And whether those changes that we've made as a result of the conference and engaging patients in making some changes would have an additional benefit to the program, whether it won't change it.
Please join the program.
Please, with the rendition as it is, even the very fact that it reaches men and speaks to them
it's free
in ways they can accept and understand. It's very encouraging.
Yeah. And then there's many organizations and people, including Movember, that have been very, very supportive of us. This is a slide we're getting ready for the EUA presentation in London, England soon. So I think we'll end there. Last comments to you, Chris, just to wrap this up then.
Yeah, absolutely. I just want to thank everyone for joining today. I think if there's one takeaway for me, it's that there is some generic information we can provide you, but that giving the best or getting the most from your physician requires making sure they understand what your priorities are and what matters to you. And so that's a little bit on us and a little bit on you to make sure that as physicians, we come to really understand your life goals, the things that matter most. And if it feels like treatment choices are being offered or suggested by someone who doesn't understand the things that really matter to you, that's the time to pause the process and make sure that we realign on your goals, your priorities, and make sure we can get you the best treatment that reflects that. Now, that doesn't mean that we have a silver bullet treatment that's going to be perfect and be without harm or downside, but almost always we can find a treatment choice that's going to fit within any individual's goals and priorities.
Love it. Thank you. Excellent finish. Thank you so much.
Is I can think about understanding you. I can't tell you that I feel it, having not been through it. So I would say, I have a couple of thoughts maybe that are important. Number one is I think you alluded to really well the sort of cyclical or bidirectional nature of the interaction between the physical and the cognitive or emotional part, right? When you're worried about having a good erection, it makes it harder to get a good erection. And so there's this back and forth interplay between the cognitive and emotional parts and then the physical parts. And sometimes that feeds each other in a positive way, and sometimes it feeds each other in a negative or impairing kind of way. And so I think it's really hard to address one without addressing the other. So for example, I'll give you a step way out of this example, but we have men who are in their 20s with no medical reason to have any erection problems at all. And they get what we call psychogenic erectile dysfunction. It's all psychological and no physiological. But you can give them things like Viagra and Cialis, and it makes them feel like the erection's going to be good, and suddenly their erections are good because they think they're going to be good. And so we get into these positive feedback loops, and also I think around prostate cancer treatment, we get into these negative feedback loops where we worry about how the erections are going to be, and that makes it harder to have a good erection, which makes it a negative experience, which means that the next time you're thinking about sex, instead of thinking about all the good sides of sex, you think about the last experience you had that wasn't very satisfactory or came with these negative emotions, and maybe there's like some shame or some disappointment or whatever other emotion tied into it, and then it makes it even harder because you're starting what should be a good experience from kind of a negative place. And so treating both simultaneously, I think, is one of the things that I found the most useful. So how to approach that, from the psychological component, as you say, I think sex therapists are great. The other thing I think varies a lot between men is around the nature of the spouse. And so people who have longer standing relationships and have established relationships with their partners and have pre-existing sort of sexual interactions can often rely on their spouse more. Those who are single have a larger number of sexual partners or just less sexual history with a partner, that can be more difficult. Conversely, sometimes when you have a long sexual history with someone, there's established routines, and the change in sexual function that comes with prostate cancer treatment can disrupt your routines, and it means having to rediscover a sexual relationship and what the nature of it is and how it may be different than it was before. And so an understanding receptive partner can be receptive, use their not necessarily as a double entendre, but a partner who understands the process. And I think part of that, it comes from the explanations from you, but also this is where it's helpful to bring a spouse or a partner to medical visits, and so that they get that expectation before. And so that's a lot of words to tell you that I think it's very common. I think it is very multifactorial, and I think because of that, there isn't one great answer about how to fix it, because it's different for each man, and each man's situation is different. Their social supports and their partner relationships are different. What they need or want out of a sexual relationship is different. And so I can't give you a recipe as to how to make it better, but I think trying to fix any one component in isolation is almost destined to fail. And so taking that broader holistic perspective is your opportunity to get success. And then the other thing I say to people, and some people are happy to hear it and some people really hate it to hear it, is there are ways to have really great intimate and sexual relationships that don't involve taking something hard and sticking it somewhere else. And so in the transition periods, as you try to rediscover a new sexual relationship with either a new partner or just in your vision of what a sexual relationship looks like, giving yourself the freedom and the grace to accept that there are other ways to have fulfilling sexual relationships that don't rely on the strength of your erection, which is typically the thing that's most affected by the prostate cancer treatments.
And not that Chris can defend all the urologists, but I do want to
No,
let
of course.
Chris respond to this one. Go for it, Chris.
Yeah, I think there's a variety of how people approach these things, to be totally transparent, and I think the variety of how people practice reflects the variety of the experience patients get. Some of that is about the physician, some of it's about the connection between the physician and the patient, and in all cases, it's critical, I think, that as physicians we address all aspects of it. I think physicians, when we think about what medicine is good at, medicine does essentially three things. It diagnoses, it treats, and it tries to prognosticate or like tell us things about what's going forward. Medicine is fairly good at diagnosis, okay at treatment, and very bad at prognostication in general. And so there are a lot of people and a lot of physicians like doing things that they can control and become very uncomfortable when they move into spaces that they either don't understand or can't control. And so fundamentally, taking someone to the OR is something within the control of a urologist, and allows them to feel under that they have self-efficacy. Now, we've kind of alluded to it, but outcomes between patients are often quite hard to predict, even for a good clinician, how it's going to be. And when things are either not the way you thought they would be or not the way you'd hoped they would be, many people and many doctors, I think, pull back in a way that is not helpful. And it takes a certain amount of
Humility, even, yeah.
And personal fortitude. I try and teach my trainees this, and it's hard to do. You have to lean into the people who are struggling. It's not rewarding, though. It doesn't feel good to spend extra time with the people with more complications. You want to spend time with the people who are doing great because they make you feel like you're awesome. But you have much less to offer them, and you can't help them as much. And you can really help the people who are struggling. But the reality is that as a doctor, it doesn't feel good. And so I think if you're not very intentional about it, people probably inadvertently, with no ill will, pull back from the people who need us the most. And as a result, leave people hanging and feeling isolated and not taken care of. And I think that's the opposite of what we should be trying to achieve in medicine.
Thank you so much for that humility as well. That open.
Literally everything you said, and one way that I would try to frame it is that if a physician doesn't understand the specific priorities, you can get down into specific physical features. So talk about, erectile strength. We can talk about erection length. We can talk about ejaculatory function. We can talk about bowel function and, perineal sensory changes. And so one of the ways I think one of the ways to really advocate well for yourself is to understand the ignorance of the physicians, and don't count on the physician to actually understand what matters just by saying, I'm a top, I'm a bottom, that they're going to get what that means and what physiological effects are most important. And so, aligning on the actual, and I try to do this just blanket. My other favorite line that I like to use when a patient comes into the room with someone else is just, how do you know each other? To try and start to get a sense of what the social relationships are that are dominant in that person's life and are important, and that'll help guide how the discussion goes. But understanding, even in heterosexual partnerships, it will maybe not shock you guys to know that many times a wife comes into a consult room and makes it very abundantly clear that sexual function in the 72-year-old man and his 69-year-old wife is not something that she cares about at all. And penetrative intercourse is probably not on her priority list. And so we have to align on what he's expecting out of it, what she's expecting out of it, what their individual priorities are. And so, there's so much variation between each individual that being clear on what physical features are important to, protect in terms of your quality of life is really key, to help ensure you get an outcome that aligns well and protects your quality of life. And I have to apologize. I have a meeting that started 5 minutes ago, so I'm going to have to bounce. And I really hope Douglas doesn't have a comment directed directly at me. But if so, get Cody or someone to pass it through. And I'll be happy to send an email back. But I'm running late to my next one.
Huge. Thanks, Chris.
All right.
Thank you so much, Chris. Really appreciate you tonight. Thank you.
Good man.
Concludes episode 14 of our podcast. For more information about our programs or to enroll in our programs, please visit PC-PEP.org. Until next time, be well and take care of yourselves.